interface. And again, feel free to type in your information in the chat if you'd like. So this with deep incisional biopsy, obviously hard to tell about symmetry, circumscription, those sort of things. You have to kind of rely on secondary features, but you look at low power, the cells look pretty pale. So if it's an epithelial lesion, it's going to be a clear cell kind of thing if it's going to be that. As we go to higher magnification, you can see that these cells are arranged in these aggregations, and they have this sort of pinkish granular cytoplasm with these little hyperchromatic nuclei that are centrally and eccentrically placed, but no real mitoses, no atypical features, anything like that. So yeah, somebody's already typed in that this is a granular cell tumor. And anybody know what the differentiation of these lesions is? Used to think years ago that they were muscle tumors. Yeah, so now we know that they're not. We know that they're really in the Schwannian category. And if you stain these, it will stain positively for neural markers. And also the granules will stain positively with this marker. I'm not sure anybody knows exactly what that is. So this is an S100 protein over here. But this marker over here is also positive for granular cell tumor, and this is a PAS stain. So the granules, they're probably Schwannian, myelin, sort of lysosomal contents, and they stain positively with PAS stains. These are often seen in African American and dark-skinned patients, and the tongue is a common site of involvement. And even though this lesion was taken by an incisional biopsy, a lot of times they're taken by shave biopsy technique, and it's very common to get overlying pseudoepitheliomatous hyperplasia. And we've seen these misdiagnosed as squamous cell carcinoma when you just get the epithelial component. So you want to make sure that you don't do that. Now, one thing about granular cell tumor, so again, this is the staining pattern. They also can stain positive in SE, but they do stain positive for PAS. That's something the board could ask you. There are a number of different settings where you can see granular cell reaction pattern. So you get granular cells in things that aren't granular cell tumor. And that's, you know, probably a little bit esoteric, but something you should at least understand. You can see granular cell fibrous papules, and granular cell schwannomas, granular cell basal cells, etc. You can see AFX, granular cell atypical fibrous xanthoma. So just realize that there are other settings where you can see granular cell tumors. And when they're multiple, they can be associated with Noonan syndrome and also neurofibromatosis. So those are some esoteric trivia that you might encounter on the board examination. Okay. Probably this lesion was probably a little papular kind of lesion. And you've got a central neoplastic process taken from area that's near the mucous membrane. We're going to higher magnification, and you can see that it's an epithelial neoplasm. Okay. And then we've got this lining. So it's almost like a cystic lesion that's lined by this apocrine differentiation lining the surface of it. And you've also got these little sort of papillary fronds. And in the center of those fronds, you've got some inflammatory cells that are plasma cells. Now we've got two different answers. We've got HPAP and we've got SPAP. Okay, now which one occurs most commonly in the mucous membrane location? Yeah, not SPAP. That occurs on the scalp most commonly. It's often associated with nevus sebaceous. So when it occurs in the groin area, and it's also usually also kind of thought to be a cyst or a little dermal nodule, it's more likely to be hidradenitis papillifera. And these also will have the central cores with the plasma cells. You don't see that as frequently in syringocystoma papillifera, but basically it's the same entity. One's got a cystic morphology on the mucous membrane, and one's a more verrucous morphology that opens up to the epidermis. If you had this thing that had some epidermal contiguity, that wouldn't necessarily just instantly make it syringocystoma papillifera. So one caveat, never use just one criterion to make a diagnosis. Here you see the plasma cells. So put everything together. Now, if you see like pathognomonic, molluscum bodies or something like that, maybe you can use one criterion, but generally we like to use, we put together all of the pieces to make the symphony. We don't just use only the wind section or the percussion section. You put everything together to end up getting a diagnosis. So a beautiful example of hidradenitis papillifera. And these again are like this. They occur in the genital area. They're often thought to be a cyst or a tumor or something like that. So somebody just takes a biopsy, but they often will do kind of an incisional biopsy. And they often will sort of enucleate. Now, there are some other things in the differential diagnosis of mucosal cysts. So here's one, also seen in the mucous membrane. It's got these large cystic aggregations in it. And if you go to higher magnification, you see that it's also lined by an epithelium. But this one has got this little sort of fine frond-like, villus-like material on the surface, the wispy material on the surface, like you can see like with cilia. So we get cilia here lining this cyst. So this is not hidradenitis papillifera. Okay. Here you've almost got what looks almost kind of like genital transitional epithelium a little bit here. And this was on the penile area. And this was median raphe cyst. So here you've got urothelial lining with some pseudostratified columnar epithelium, some mucin-containing cells, and often you'll see a little bit of cilia on these lesions. So this is a median raphe cyst. These are thought to arise from an incomplete closure of the urethral vestiges there in the penile area. Here's another cyst. Okay, notice this one is deep to the skin. We don't know where this one is. And this one's lined by a very thin single layer of epithelium. They've got these little snouts to them, but this is not really apocrine differentiation. And once again, there's something on the surface. Maybe there's cilia here also. Okay, so this was on the trunk, and this is what we call a cutaneous ciliated cyst. These are usually on the lower extremities of women. They have this very simple cuboidal or columnar epithelium. And if you look carefully, you can see that it's got some fine cilia on the surface. And that's thought to be an analogous type of lining to what you see in the fallopian tube. These are seen sometimes in men, but mostly in women. Okay, so vast majority of those seen in women. So make sure you know some of these less common cysts. I would also recommend learning a little bit about the branchial cleft areas. There are about 5 or 6 guys that are pediatric dermatologists, like Larry Eichenfeld and Sharon Friedlander and a few others that rotate on and off the board, and they like to submit some questions. So every year they have some peds derm questions on there. So make sure you know some of the pediatric dermatology things that they like to ask. And they like to ask about cysts. They like to ask about hemangiomas. So if you want to get some points, study up a little bit on your pediatric derm. Okay, superficial and deep infiltrate. Low power, you can tell these are lymphocytes. So at this point, all your third years, you shouldn't even have to go to higher magnification to come up with a differential diagnosis. So you think of the lymphocytic infiltrates here. Classic ones, they talk about the 5 lymphocytic infiltrates, but you can expand that to about 8 or 9. You should expand it a little bit because there's several other things that can give you a lymphocytic infiltrate like this. So when you get a lymphocytic infiltrate, then you say, well, what are some of the options, things that you look at to kind of be more specific in the diagnosis? So yeah, if there's mucin without any epidermal involvement, you think of the possibility of the tumid form of lupus erythematosus. And anytime you think about that, you should instantly cluster reticular erythematous mucinosis, which is probably the same disease. If you see papillodermal edema, you think of polymorphous light eruption. If you see nothing, you think of the gyrate erythemas, of which there's about 4 or 5 of those that can all give you that pattern. I wouldn't put sarcoid in there though, somebody mentioned that, but I would put indeterminate Hansen's disease in there because that can give you a perineural and perivascular infiltrative lymphocytes with only a few histiocytes in the early stage of that. if you see lymphocytes and plasma cells, you should think of Lyme disease, which can give you that same pattern, and with the plasma cells, which is more common, so everything with chronic and migraines. So anyway, there's more than just 4 or 5 of these. So make sure that you know what all of these are. So in this case, there happened to be a little bit of mucin here, which you can see in this field. So this would favor the tumid form of lupus erythematosus, which looks like this. People get these red, fixed, usually non-scaly lesions because they don't involve the epidermis. They're usually not atrophic because they don't involve the epidermis, or they don't really cause a lot of dermal atrophy, and they just kind of sit there. They're there for years. They're often associated with sunlight exposure. So tumid LE responds beautifully to treatment with Plaquenil. So again, just remember those various things. So what are the 8 Ls? We've kind of been over those. So this is the tumid form of LE, polymorphous light, the lymphocytic infiltrates. And Yesner's is probably a wastebasket term that probably really is tumid LE and polymorphous light eruption. Probably not really a Yesner's disease itself. Sorry, Dr. Yesner and Norman Kainoff, who was an attending at NYU when I was a resident there, and a good guy. He was the other one on the paper years ago, but it's probably not a real disease. Lymphomas, sometimes B-cell lymphoma, and especially cutaneous CLL when it involves the skin, can give you lymphocytic infiltrate. So that's another one that you definitely need to put in there. Indeterminate leprosy, and then Lyme. So think about all of these variations. And of course, Louis can do anything. So those are a little larger differential diagnosis list than just the 5 that you find in most of the general textbooks. Okay. Low power. There's a superficial perivascular infiltrative cells here. There's something's going on between the epidermis and the dermis. Okay, now this is probably second order type question. Okay, so this is where they're going to show this to you. You recognize pretty fast that it's a subepidermal blister. You know the way to diagnose subepidermal blistering diseases. You look to see what is the nature of the infiltrate, right? So this should be pretty much review, most of you guys. So we're going to look and see what's in that infiltrate. And guess what? There's a lot of eosinophils. So lymphocytes, eosinophils, diagnosis, bullous pemphigoid. Now, if it's a woman, diagnosis is herpes gestationis, right? Because it looks exactly the same. Can't tell it apart. So it's classic. Now, there are a couple things in the differential diagnosis. Epidermolysis bullosa acquisita can give you a pattern that can be identical to pemphigoid. So it can give you a pattern that looks like this with lymphocytes and eosinophils and has normal overlying epidermal chain, no change in the epidermis, and may or may not have any scarring. Okay. So just make sure you know everything there is to know about blistering diseases you should know, because they're going to ask. So you may as well just be prepared. They're going to ask about the patient membrane zone, because you have guys like Dr. Yancey that have submitted questions over the years. He's going to expect you to know all that stuff. They're going to ask you about the scarring versus the non-scarring subepidermal blistering diseases, the cicatricial pemphigoids, the mechanobullous diseases. So I'd recommend knowing all about pemphigoid and all about the immunobullous disease for sure. Now, if you don't want to waste too many bet cells on learning all of the esoteric variants of the epidermolysis bullosa variants, they probably won't ask too many questions about that, because some of those things are so esoteric that most attendings don't even know it either. But you might get some stuff about EBA, for example. You might get some stuff about dystrophic EB, some things like that, about the electron microscopy, about the absence of type 7 collagen, and some of those sort of things. So you very well might get some questions about those. The bullous pemphigoid, you need to know everything there is to know about it. You need to know the immunofluorescence pattern. You need to know what happens if you do salt split skin, where the antibodies map. If you do a type 4 collagen immunoperoxidase stain on a blister, where does the type 4 collagen map? It maps to the bottom of the blister. But with the salt split skin, it goes to the top. So you need to know which of the two areas you're going to see. So this, I would recommend, you may as well just go ahead and commit this to memory. because they're going to ask you questions about this. And so when I was taking it, they've added a few antigens in the last 30 years since I took the exam. But basically, I used to use the mnemonic BLT coffee, because you think about bullous pemphigoid antigen being high up, and then you know, type 7 collagen and all that is way down at the bottom. So if you just think about where the 1 molar sodium chloride causes the split just beneath laminin, you can think about where things map. What if you want to do to distinguish between, say, bullous pemphigoid and EBA, which is the most common use of that technique. It splits it at that site, and you look to see where the antibody. So you take a normal skin, you incubate 1 molar sodium chloride, and you take the antibody and put it on there and see where it maps, and it gives you the diagnosis. So anyway, make sure you know this. They're going to ask it, so you may as well just go ahead and expect it. Okay, this one we've already done before. Should be pretty much reviewed for most of you. Okay. Psoriasis hyperplasia, and then we've got this column of this parakeratosis here. A couple of dyskeratotic cells at the base. I think we had one of these a couple of weeks ago. Everybody know the answer? Poro. Disseminated superficial actinic porokeratosis. They wouldn't necessarily know it was DSAP here. You just know that it's poro. So again, we talked about this last week with the psychotropica. So again, just make sure you know this. And now that we know the enzyme deficiency, make sure you know anything that's associated with a gene and a disease that's related to dermatology. So they're going to ask that because it's new. It's in the literature for the last couple of years. So make sure you know that. Now, sometimes you'll biopsy the center of poro and you get like a dense lichenoid infiltrate. And then sometimes you can get AK or you can get squamous cell carcinoma associated with it. Well, one thing I would probably say, first of all, in the differential diagnosis, there may be some other things that may throw on there to kind of throw you off. So there are other situations where you can get cornoid lamellae and it's not poro. Now this is this is a mispronounced disease. Everybody calls it flagels, but it's actually, his name is pronounced Flegel. And he actually was at a dermatopathology conference a few years ago. And he was announced as Dr. Flegel. So don't call it flagels, call it Flegel. Yeah, so Drew said he didn't see much dyskeratosis, and you know, you don't have to see a lot. So, you know, sometimes you do and sometimes you don't. So don't just, again, don't throw that out if it's not present. Okay. So these are some situations where you can get cornoid lamellae, but it's not poro. Cornoid lamellation. So we talk about reaction patterns like spongiosis, like FAD, epidermolytic hyperkeratosis. Well, cornoid lamellation is yet another one of those. So sometimes you see it in psoriasis. Sometimes you see it in an LPLK. Wong type dermatomyositis. You guys heard of that before? The Wong type? Okay, so if you haven't heard of it, go back and bone up on it a little bit. It's dermatomyositis that looks like PRP that's got follicular involvement. Wong type dermatomyositis, relatively rare. Keratosis lichenoides chronica. Okay, so that is also known as Neckham's disease. Neckham's disease can give you cornoid lamellation. You can get Grover's disease with little cornoid lamellae sometimes, porokeratotic variant of Grover. So that's a relatively newly described variant of Grover's. Fox fordyce, LSNA, AK, so-called porokeratotic ecrine osteal and dermal duct nevus can give you cornoid lamellae. Ichthyosis hystrix, the epidermolytic hyperkeratosis, can see that, and Pachyonychia congenita. So I don't know if he'll ask you any of these, but they might. So just realize that cornoid lamellation is not specific for poro. Usually it is. If they show you something like this, probably show you a better example than this, just so you'll know. So yeah, Drew, they wouldn't show you one that didn't have the dyskeratosis, so don't worry about that. But they might ask you some other settings where you can see cornoid lamella formation, and it's not really classic poro. Okay, here's another one where they're going to show you this, expect you to get the answer, and then they're going to ask you some second order questions. So they a lot of times they're going to say, okay, well, we're going to give them the answer of the pathology. You expect they better get that pretty quick. And then we're going to ask them something like, which disease is this condition associated with? Or which enzyme deficiency is this associated with? Or the disease associated with this finding is inherited in which fashion? So those are the kind of things you might get. So hopefully everybody knows what this is. Yes, angiokeratoma, not very difficult diagnosis to make. Always GM2 gangliosidosis. Well, I'm not so sure always. There's almost never that any question on an exam where always is the right answer. So beware of that. If they put something like that on there, it's probably wrong. There's actually about 3 or 4 different diseases that are associated with angiokeratomas. It's not always the GM2 gangliosidosis. That's one of them, but actually it's not the most common. And other things in the differential diagnosis, just so you know, sometimes these things get sent into us as rule out melanoma because they're black. And there are several variants of angiokeratoma. There's the angiokeratoma corporis diffusum. There's the solitary type. There's the Mabelli type. So there's several different subtypes clinically. So Fabry's, which is alpha galactosidase deficiency, not gangliosidosis. It's X-linked recessive. That's the most common one. That's the one that we've heard of since I was in medical school. That's the one that they've known about the longest. Fucosidosis, autosomal recessive, lack of fucosidase. It's another one. Sialidosis deficiency, that's where you get a deficiency of neuraminidase and beta-galactosidase. That's the one that you're kind of talking about there, the GM2 gangliosidosis. So anyway, just remember that there's not just one disease, there's 3, and there may even be more. So they sort of figure these things out periodically. And if they come up with something relatively new that makes derm times before the board's written, make sure that you're aware of it, because they like to ask questions when things come out that are relatively new that relate to dermatology. Another one. Okay, so a lot of these are pretty straightforward diagnoses, and we're going to be asking questions here about the diagnosis and about a second order question. So we got a dome-shaped papule. It's got the small clear staining cells at the periphery that have a lot of glycogen in them. The whole thing overall looks kind of like a wart. So if you think wart with clear cells, it looks like the outer root sheath of a follicle. What do you think about? There's another example of an area right over here. Yeah, trichilemmoma. Trichilemmoma. Okay, so this is a trichilemmoma or a trichilemmal verruca. And what disease are we looking at here that's associated with this? Should be kind of reviewed for you now also. Cowden's. We talked about this a couple of weeks ago also. So which syndromes are in this sort of setting? Okay, well, Cowden syndrome, autosomal dominant. Pull this down and I can see what it says, because I think, a second. I can't move it for some reason. Well, there's several diseases we need to know about here. So I'm going to go just through the little list here. These are the P10 mutation disorders. Okay, so that's what I wanted to say. So which diseases are in this P10 family of diseases? You need to make sure that you know these. The board likes to ask this kind of stuff. So move this up a little bit. This is phosphatase, tensin. I can't see underneath there, but these are mutations in that general area, homeobox mutation. It's on gene 10q. It's a tumor suppressor gene. Wipe out the tumor suppressor gene, you get tumors. Benign tumors, but you get a lot of them. So Banyan, Riley, Ruvalcaba. I think that's associated with some vascular lesions also, but make sure you know that. Proteus syndrome is in this family. Proteus-like syndrome. Adult Laramide-Duclos disease. Now, I don't know what that is, but I put it in here, so make sure you know what it is if you want to get an extra point. And then the autism-like disorders with macrocephaly. So again, these are the P10 mutation syndrome disorders. And if they're going to ask anything, they probably are going to ask Proteus and Bennion Riley ruvalcaba. That's one that we talk about in grand rounds and stuff like that. So, and yeah, to answer your question, you can see HPV-induced warts with trichelemal differentiation, and it's just coincidental and doesn't mean that they've got Cowden. So yeah, anything that is syndromic can occur sporadically, and it's not necessarily associated with a syndrome. Okay, shave biopsy. A little harder because we just have a shave of something, but it's got low power, pale cells. We're going to higher magnification, and it's got a little epithelial hyperplasia, but the main action is going on in the dermis. So is it inflammatory and is it neoplastic, or is it maybe a quote, neoplasm that's comprised of inflammatory cells? We're going to higher magnification. These cells have abundant cytoplasm. There's an admixture of, there's some eosinophils here, there's some lymphocytes, there's some large cells with relatively abundant cytoplasm, a little bit of fibroplasia down here at the base. And then now we've got some cells that have multiple nuclei in them with some fine cytoplasm, and then some cells that have some lipid in their cytoplasm. Here's one that's got a little incipient wreath of some nuclei here. Okay, and this is what it looked like clinically. I don't see anybody just chiming in with lots of answers, so it means you must not know very much. You don't feel very confident about the answers. Everybody putting it in the chat room. Good. Somebody put JXG. Good. Now, JXG, depending on when you biopsy it, can look different. So was this probably a JXG that had been present for 10 years? Or maybe a JXG that's been present for like maybe a few weeks? This is more of a proliferative form of JXG where we don't really have a lot of two-ton giant cells yet. And if you get these lesions in an early proliferative stage, they actually can have a lot of eosinophils in them and can look sometimes even more like a pseudolymphoma. You may have to look hard to see any two-ton giant cells at all. So just realizing a JXG in an early stage, it doesn't look like a classic JXG that's seen later in life, or later, if an older one that's been present for a long time, or in an adult. And we call them JXGs, but 40 to 50% of them occur in adults, so they're not only seen in kids. Sometimes they're multiple. A lot of times they're just solitary. They can occur in bad locations sometimes and cause problems with just the mass effect. They can be associated with underlying conditions in some cases. So remember that they can be associated with hepatitis, tumors, and even they've been associated with, I believe, with neurofibromatosis, and also associated with a myelocytic leukemia. So they rarely can be associated with other conditions. So just remember that while they're usually just coincidental, don't mean anything, they can sometimes be associated with other things. And they can be associated with the differential diagnosis of some of these others. So what are some of the non-Langerhans cell histiocytoses? There's a lot of them. These are some of the more common ones. So if you're going to get asked any questions, these are probably the ones you might get asked about. Benign cephalic histiocytosis. 1 or 2 lesions on the scalp, usually when a kid's born. They're often present at birth or shortly after birth. You get a generalized eruptive form, where you get two-ton giant cells and lots of lipid-laden histiocytes, usually not a lot of lymphocytes. Indeterminate cell histiocytosis. Cells look like Langerhans cells, but they don't stain like Langerhans cells. They're not exactly like Langerhans cells. Obviously, JXG, progressive nodular histiocytoma. That's almost kind of like a xanthogranuloma with a lot of two-ton giant cells, more fibrosis and whatnot. Gets larger and grows over the course of time. And the necrotic xanthogranuloma that's associated with paraproteinemia. So I would just recommend learning a little bit about those. These others, multicentric reticular histiocytosis associated with severe arthritis, Erdheim-Chester disease. Basically, it's like a storage disease in a way. They get large lymphocytes. They store this lipid. Cucci's disease. They get a necrotizing lymphadenitis. And then xanthoma disseminatum. They get a lot of these xanthomatous type lesions. Again, they can have some two-ton giant cells in there. It kind of looks a little bit like eruptive histiocytomas. And then Rosai-Dorfman disease, you get the plasma cells, nodular infiltrates with the large histiocytes that stain positively with S100 protein. So you know, they probably won't ask a lot of questions about this, but if you want to maybe get a couple of bonus questions, bone up a little bit on that before the exam. Okay, we got a punch biopsy. Got a lot of discohesive areas in the dermis here, maybe a little bit of an erosion up here. So at low magnification, hard to be sure what's going on. Is it inflammatory, neoplastic? I mean, there may be some suppuration over here. Certainly it's not a lymphocytic infiltrate like we saw with the lupus before. Go to even progressively higher magnification, and there's something going on in these areas here. There's kind of an admixed infiltrate. There's some neutrophils. There's some histiocytes here. There's some dilated follicles. It kind of looks sort of like maybe some sort of suppurative process. Yeah. So again, once you get into this category, you've got a differential diagnosis of a number of things. So you've got ruptured folliculitis, you've got Yaki's granuloma, you've got an abscess. So you got to just start thinking in terms of the suppurative conditions, things that have neutrophils that are predominant. There's a whole host of different things that can give you that pattern. So without further information, all you can do is just kind of put it into like a pyogenic, either sterile suppurative process or something that's infectious. And then you might even put in some of the things like the neutrophilic dermatoses, like maybe sweets or maybe like halogenoderma, things of those nature. So think about those also when you get suppurative processes like this. So obviously here, you're going to go on a bug hunt, you're going to look for infectious agents here, you're going to do special stains, and then you're going to need clinical correlation. So in this case, it looked like this. The guy's entire scalp was basically scarred down with these areas of suppuration and pus emanating from some of these areas here, and a lot of scar. So when you see this, the diagnosis is obviously folliculitis decalvans. It's in that category of all these suppurative folliculitis on the scalp that ruptures with scar and then it recurs over and over again. And there's sort of a tetrad of different diseases that can give you this same pattern. So see it histologically, clinically, you kind of throw all these things in there together. Dissecting cellulitis, basically the same disease. So it's just another variant of that. Folliculitis and perifolliculitis, capitis, abscedens, and Sifodians. That's basically the same thing. So there's a lot of names for this general process. Now, Lichen planopilaris clinically can sometimes look alike. And sometimes you get a bad case of Lichen planopilaris where you get the perifollicular lymphocytic infiltrate, destroys the follicle, ruptures, and you get a secondary suppurative folliculitis. So you can get a secondary neutrophilic influx in Lichen planopilaris on occasion. So these are the other sort of the classic tetrad of the diseases that give you this same pattern. Hidradenitis suppurativa, shouldn't be E, should be an A at the end. Folliculitis decalvans, which includes all of that sort of second cellulitis category. Pyoderma gangrenosum sort of falls into this spectrum also. And then pilonidal sinus is in the same category. So somebody that's got these conditions, they basically are all in the same general family of conditions. Sterile suppurative folliculitis with rupture, scar, and you need to shut off that inflammation. And now, as you all know, TNF alpha inhibitors are being used to treat a lot of these conditions. Okay, a bug. And you're going to get some bugs on the exams. So they'll show you some. They probably will show you more clinical photos of the bugs, gross photos of the bugs. But if you're creative, you can tell this bug is where is it located? Number one, is it in the skin or not? Not in the skin. It's not in the skin. Okay. This is not in the skin. So it's sitting outside the skin. So actually what somebody did here is that they took one of these little buggies and they put it in a formalin bottle, they sent it to us, and we made a slide out of it. If you look at it, it's got a little head here. It's got a couple little arms over here. It's got a little pincer-like structure over here. Okay, now somebody said tunga penetrans. But where does that live, tunga penetrans? Where does that live? It lives inside the skin. It burrows into the skin. Okay, so that's no good. This is outside the skin. This never made it into the skin. This bit you and it stayed outside of you. This didn't burrow like scabies. Myiasis. Okay, if you see that, that's a maggot. It looks kind of like a long football. It's got rings of black spines around it. We don't have that here. We got this little guy that's got a couple of arms here. These are his little pincers at the edge here. There's a little, look at that, looks like a claw. It's like you're going to Red Lobster, okay? And he got a little claw, he's pinching this. Yeah, it looks like a little crab. He's pinching. This is a crab louse. Crab louse. Pediculosis. Okay, this is what we were seeing. There's his head, and we were looking at this little spine over here. Okay, so they're probably not going to show you a histology of that, but they could sure show you this, and they probably will show this to you. So be prepared to get some ectoparasites on the exam. This is PHTHIRUS pubis, crab louse. These like to live in your pubic hair area. And where else do they like to live? On your eyelashes and eyebrows. Now, why do they live there and they don't live on your hair? Well, probably because they kind of need those hairs to be a little bit thicker in those locations than the actual hair that grows on your scalp. So they don't live in your scalp hair or in your, you know, they live mostly in the pubic hair. They can sometimes be in your axilla, but they like that kind of hair. And I'm not sure 100% that's the reason, but I suspect that's probably part of it. Okay. So again, these are the mites. These are in the order of Anopleura. Okay, so you've got 3 different lice that you need to know about. There's Pediculosis capitis, Pediculosis corporis, and Pediculosis pubis, PHTHIRUS pubis, which is what this one is. It's actually, this one's a different genus. We thought pediculosis is the name of the disease. So pediculus is the actual genus, and PHTHIRUS is the genus for crab louse. So these are the little nits that you see. Notice, look how long the body is in these. Okay, so this is a different animal than the PHTHIRUS pubis. It looks like a crab. These things don't have the big long pincers on them. They like to, what they do is they live in your clothing, or they'll live in your hair, and then they form their little nits. They cement that to your hair shaft, and then the little egg inside there eventually pops open. And this thing, when they produce carbon dioxide, and it actually kind of pops off, just like popping off the bottle of a soda pop in a way. That's how those things kind of rupture and they get out and then get your body. So here's PHTHIRUS pubis, the crab louse. Here's the body louse, a little shorter body than the head louse, which is a little longer. So head is longer, body is short. Remember that. So they may show you that on the exam. That's the lice. The other thing they might ask you are some of the diseases that are associated with lice. So make sure that you know that also. Typhus, for example, all those kind of things. Okay, punch biopsy, very, very sparse infiltrate. So what do you do when somebody throws a biopsy in front of you that's got basically nothing on it? Okay, you have a normal skin differential diagnosis. So you have a systematic approach. Okay, it depends on, I don't care how you do it, but I usually like to look in the dermis, say, well, there's really minimal inflammation here. You look, see if there are any cells in the dermis. Is it mainly a vascular process? Well, there's sparse infiltrative cells, might be urticaria pigmentosa. Let's look, are there melanophages? Is it a pigmentary process? Let's look at the epidermis. Let's look at, is there any melanin there? Maybe it's vitiligo. Maybe it's some kind of hypopigmented disorder. Maybe it's pityriasis alba. Let's look at the cornified layer. See if there's any abnormality there. Sometimes you get tinea with minimal inflammation. Maybe it's tinea versicolor. Maybe something applied exogenously to the skin. So those are the ways at least I approach a normal skin biopsy. So you got to systematically know what to look for. If you just look at it at random, you're going to miss the diagnosis. So you have to have a way of going through it. And here, we start looking at the epidermis, and what have we got? Classic example, yeah, Tinea versicolor. Good. So hopefully everybody would have gotten this right. Now, is that epidermis normal beneath it? No. Should have more pigment there. It's got none. So they might say, okay, well, here's the diagnosis. How come the epidermis is white in this case? How come it looks white as opposed to this color? So there's two reasons. Number one, maybe they went, I got a tan and this just didn't tan as much, or maybe this is the winter time. This is a normal skin color. It actually made it white because it's got azelaic acid in there. So they might ask you about that also. You can do a Woods lamp on this, and it does stain the, you can actually see the organisms with the Woods lamp, but mainly you see the loss of pigment and the contrast with the background normal skin color. So if they're going to show you this on the exam and they're going to expect you to make a diagnosis, they're going to throw some other fungi in there. So they probably would, it'd probably be multiple choice. They might say the correct diagnosis in this case is, they've got dermatophytosis, they might have candida, they might have pitted cheilitis, they'll have this, they might have tinea nigra. And so you got to make sure that you know all of those things. And then because you start scratching your head, say, well, gosh, you know, could it be dermatophytosis? I mean, are these really spaghetti meatballs, or these just hyphae that's got maybe a couple little chlamydia spores possibly associated with it? So just make sure you can tell the difference between that, because they're going to, usually you can eliminate 2 or 3 pretty quickly, but they're going to put 2 that are really hard, that you might choose the wrong one. So make sure that you can tell the difference. So why does Tinea versicolor turn the skin either darker or lighter? Well, people have studied this. You know, they've looked at it, and there's a literature on it. So some people think it's prevention of tanning. Maybe it's, some people think it has to do with changes in the melanocytes, has alteration of the melanosome granules, lipoperoxidation by malassezia. So there's all these theories as to why it causes the changes. That's why it may get hypopigmented. And on the right, these are some of the reasons that it might get hyperpigmented. So yeah, it's just kind of an interesting deal. A lot of people have looked at this. We do know that there's azelaic acid, and that is a chemical that is commercially available that is used to treat melasma. Not a very good treatment for melasma, but it does work in some people, and it's one of the ways that it's thought to actually cause slight. Okay, somebody needs to mute their thing, please. So here we got an incisional biopsy once again. And we've already seen a couple of cysts this morning. So we've got another cyst. Hopefully you guys can recognize that. Okay. So we diagnose cysts. We look at the lining of the cysts. And this one, somebody's already put the diagnosis of Steatocystoma. But what if I just showed you this field? Would you call this Steatocystoma? I hope the answer would be yes. Because when you see this corrugated lining with this, it's almost kind of like it's got keratin lining in it. It's an adherent single layer of compact cornified material that's thrown into folds, and it's basically corrugated like this. That's classic for Steatocystoma. You can call it shark tooth. I like that. So yeah, when you see that pattern, even if you don't see very many sebaceous glands, you should still think about the diagnosis. Of course, if you see the sebaceous glands, and you know, Miller time, you got the diagnosis, not any problem. But if you see this alone, it's very helpful. So that's virtually pathognomonic. Yeah, somebody says, well, can you see similar lining in dermoid tumor? Yeah, not usually as much of this as in dermoid. So I don't like that. But again, in dermoid, you're looking for hair shafts, you're looking for sometimes even other things, sometimes even weird stuff like teeth that are in dermoid. So in dermoid cysts, look for other structures than just lining. But you can get a little bit of the corrugated membrane with that too, just it's not as prominent as here. Okay, so they might ask you some questions about this also. Now I'd still call it a sebaceous Steatocystoma probably, but if you want to call it a sebaceous duct cyst, you can, but they're not gonna, that's not gonna be an option on the board. They won't have that on there. So these can be solitary or multiple, and they also can be inherited. They can be autosomal dominant. So make sure that you know that. And they can be associated with other syndromes. Pachyonychia congenita type 2, Alagille syndrome. So just make sure that you realize that occasionally these things can be associated with other conditions. Multiple polymatricomas be associated with glioblastoma multiforme and Friedreich's ataxia. Or some people, I'm not sure they still call it Friedreich's ataxia, but it's be associated with neurologic disorders. So just realize when you get these multiple cysts, sometimes they can be associated with other things, and the board might ask you about that. So eruptive vellus hair cyst, again, can look a little bit like this, doesn't have the sebaceous lobules, usually a thinner lining, has got multiple vellus hair shafts in it. So what's the genetic mutation in Steatocystoma? Well, it's this KRT17 gene, okay? And I'm going to minimize the chat real quick so I can read this. There we go. So this basically partners up with this keratin 6B gene to form these networks and whatnot. So that's why these things may be associated with these other syndromes. So it's a keratin 17 gene that's associated with this. A little bit different gene than some of the others that we have to know about. So again, whenever there's a gene mutation, remember the keratin gene associated with a dermatology disease, you're likely to encounter it. So beware. If you want to get the question right, remember keratin 17 associated with steatocystoma. Okay. So here we've got a chat back up. Shave biopsy, neoplasm, epithelial, follicular, horizontal orientation, plate-like involvement. Notice that the individual structures are primitive mantle with basaloid proliferation, extending pretty deeply into the dermis with a lot of fibroplasia. Yeah, fibrous, epithelial tumor of Pincus. And the differential diagnosis is TFI, but that doesn't usually give you quite as much basaloid differentiation. If you just had like here only, kind of this superficial, and they're more kind of like these manteloid areas here, that's a better diagnosis. But once it gets down into here, you're in the TFI, you're into the fibroepithelial tumor of Pincus category. And that's thought to be a variant of basal cell. You get clefts, like you see here, between the basaloid aggregates and the fibromucinous stroma. Okay, sometimes you'll see a little nodular basal cell element in these. And these usually look like this. They're little skin-colored papules, often on the trunk. Clinically, nobody thinks they're basal cells. The best treatment here is not desiccation and curettage because of the fibrotic stroma. It doesn't respond as well to that. So you really need to excise these if you're going to treat these. And, their indolent lesions are often sent in as a nevus or something like that. They're usually never even thought to be a basal cell. And they have a very low-grade biologic behavior, so you can excise them. Most people do. Probably don't necessarily have to. Okay. So I'm not aware of that one being associated with the syndrome. So you're lucky. Nothing to worry about now. Okay. Superficial punch, probably. And we've got an inflammatory process. Which of the 9 patterns of inflammatory disease are we looking at? We've got a superficial perivascular infiltrative cells here, probably some lymphocytes. We've also got some abnormality going on in the papillary dermis and maybe the reticulodermis, but mostly the papillary dermis. And now, what reaction pattern are we seeing here? Yeah, well, you've got LSNA, but your reaction pattern is sclerosus. So you've got a decrease in the number of fibroblasts, an increase in the amount of collagen with homogenization, and this is occurring in the papillary dermis. So yes, this is lichen sclerosus atrophicus. We've got a thick cornified layer because the patients rub these lesions, they're poritic. You've got a true blister between the epidermis and the sclerotic collagen, which is fairly common. You can get bullous lichen sclerosus and atrophicus. This has some red cells in it, so it's not just an artifact. It's a real blister. So it really and truly gets vesicular in these patients a lot of times with a markedly thinned epidermis. So thin epidermis. You can still get a pretty thick cornified layer when your epidermis has only got 2 cells in it. So that shows you that you can still make a lot of keratin even though you just have a few keratinocytes left if you rub it, which is kind of interesting. So you don't necessarily have to get pseudoepitheliomatous hyperplasia to get the hyperkeratosis here with, you can get epidermal atrophy and marked thickening of the cornified layer at the same time. So this is what this condition might look like. The groin's a common location, but also you can see it in the glabrous skin, the trunk, the back. You've seen lots of different locations. If you get involvement of the reticular dermis, we refer to that as morphia with lichen sclerosus. So a lot of times it looks like LSNA. You take a biopsy, but it goes deep. So when it gets down to the reticular dermis, by convention and definition, it means that it's morphia with LSNA, not just purely LSNA. And the inflammatory infiltrate here, lymphocytes and often plasma cells. Now make sure you know, that's why it's important not to just jump to the diagnosis of LSNA. That's good that you can get the diagnosis right, but you can fall right down a major pit if you don't remember the other things that can give you sclerosis. So remember, scleroderma, morphia, chronic graft versus host disease, radiation dermatitis, toxic oil syndrome, like the morphia scleroderma conditions associated with that. So just remember other things that can give you sclerosis. It's a reaction pattern and not just jump instantly to the diagnosis of LSNA. Happened to be the right diagnosis that time. Just remember some of the other things like that. Last question. Okay, we've got a deep incisional biopsy. It's like a spindle cell proliferation. Okay, this should be reviewed for you too, hopefully. We've already talked about spindle cell neoplasms several times this year. And the cells are arranged in fascicles that interweave. So for those of you that like to get the right answer, it's dermatofibrosarcoma protuberans. Okay, so we throw that on there, expected to get it pretty quick. Might even tell you what stain is used to confirm the diagnosis, which is obviously CD34, as you see here. But then we might say, what's the genetic mutation associated with this tumor? This is one of the few soft tissue tumors that they very well might expect you to know. And they might even ask you what non-surgical treatment is available for this disease. Okay? So those of you writing the answer down is correct. Gleevec is correct answer there. And if you get a pigmented variant, Bednar tumor is associated with that. And these are just some other soft tissue tumors in the differential diagnosis. And this, I'm going to make this small also, is the genetic mutation for this entity. So it is a chromosomal translocation. Yes, and those of you that put platelet-derived growth factor beta, basically what happens here is you get a fusion of the alpha chain of type 1 collagen with the platelet-derived growth factor beta gene, as you see here demonstrated in these little diagrams here. And this turns on the cells and makes them proliferate, and you get all of these fibroblasts, if you will, which is the cells we think are really the cell of origin of this, is a fibroblast-like cell, forms a tumor. And sometimes, if you get this, basically this translocation with deleted genetic material at the tips, you'll get this ring that forms, a little ring donut chromosome that's associated with a 1722 translocation. So make sure that you're aware of this gene mutation here in DFSP. So that's one of the few things that they might ask you about here. And I think if you know these various things, you'll get some points on the board. This isn't everything they're going to ask on the board, obviously, but it's a good sort of tip-off. And I think we're going to have another board review with a bunch of questions and answers we're going to do in the fall before the board exam with Dr. Regal and the rest of our team to get you guys prepped for this thing so you'll all pass, which I know you all will anyway. No one that's ever taken lessons from me in this have failed. So you can't be the first one. So we expect everybody that's going to studying these sessions is going to nail the exam. So have a great weekend, and we'll get another, I think next week we may start with an introductory talk, I believe. I'm not sure. We'll get you the schedule and we'll go from there. Have a good weekend.